Ray here, Vet Triage. We are continuing through this issue of Veterinary Surgery from November 2024. It is another case report on a dog. This is pleomorphic sarcoma secondary to proximal femoral epiphysiolysis with bone infarction over 4 years after cementless total hip replacement in a dog. The study comes out of the Specialty Center in Ohio, as well as a vet school in Texas A&M, and another specialty hospital in Houston, Texas. The objective is to report a capital physeal fracture as a result of a bone infarction with subsequent neoplastic transformation 4 years after total hip replacement. This is a 5-year-old female golden retriever, spontaneous right limb lameness. Pelvic limb radiographs showed a displaced capital epiphysis and proximal femoral changes consistent with a bone infarction. They performed a cementless total hip replacement, a radiolucency adjacent to the femoral stem at the greater trochanter, partial calcar resorption, and stable implants were found on pelvic radiographs 52 months after surgery. They explored the surgical site for a tissue biopsy and bacterial culture. No growth on the culture. Biopsies were non-specific. They performed a right hind limb amputation 61 months post-op, and that was consistent with a pleomorphic sarcoma with no metallic or polyethylene particulate debris present. 9 months after surgery, there was evidence of regional and distant spread of the cancer. Introduction. Femoral capital physeal fractures are thoroughly documented and common in skeletally immature dogs and cats. So again, a case report like this is not meant to be statistically significant or a statistical study. It's meant for veterinarians in training, residents especially, to learn about the history of the literature on this topic, as well as what new techniques or what have you this adds to the literature. So femoral capital physeal fractures are traumatic in origin and classified as Salter-Harris type 1 fractures. By contrast, spontaneous atraumatic separation of the capital epiphysis or slipped capital femoral epiphysis, reported less frequently, has an uncertain etiology. This condition is analogous to those in children, which most often have an idiopathic etiology involving a combination of endocrine and mechanical factors. So the classic example in obese orange male cats is maybe related to testosterone, for example. Acute chronic and acute on chronic presentations of slipped capital femoral epiphysis have been reported in dogs and people in acute cases that have a short history of clinical signs, less than 3 weeks, no trauma or mild trauma. In children, an unstable slipped capital femoral epiphysis presents a high risk for the development of avascular necrosis of the femoral head and neck. The latter can also be a complication following primary fixation treatment of slipped capital femoral epiphysis. Successful treatment of both capital physeal fractures and slipped capital femoral epiphysis by total hip replacement has been reported in dogs. The blood supply to the proximal femur consists of a network of extraosseous, intracapsular, and intraosseous vessels. The femoral head receives a blood supply from the ascending arteries of the femoral neck, which travel within the joint capsule and form an incomplete vascular ring at the junction of the femoral head neck. In mature dogs, ascending vessels from this vascular ring supply the femoral head and the anastomose with femoral neck arteries. The vessels penetrate the physeal scar to supply the capital epiphysis. In immature dogs, there is no penetration of the capital physis and therefore no collateral circulation. This makes the blood supply to the femoral capital epiphysis in immature dogs more vulnerable to the disruption by trauma and other insults. Such disruptions can lead to abnormal development of the femoral head and may play a role in the pathogenesis of slipped capital femoral epiphysis, among other conditions. Infarction of the femoral head and subsequent osteonecrosis because of the epiphyseal vessel injury from hip subluxation have been reported. Ischemic bone infarction is a hypoxia-driven pathologic process of osteonecrosis of the metaphysis and diaphysis of long bones. Following an infarction, A complex repair process begins in the affected cancellous bone and medullary canal. Regional hypoxia caused by lack of blood supply activates resting multipotential mesenchymal stem cells. These stem cells are present within the fatty bone marrow and along the endosteal surface, where they remain during skeletal development. Ischemic injuries activate stem cells to proliferate and initiate repair of the injured bone following medullary infarction. The stem cells have pleomorphic capabilities and can form osteogenic and chondrogenic matrices, as well as fibrostoma and adipose cells. The fibrostoma promotes neovascular invasion from the periosteum, helping to form a cancellous bone remodeling unit in which deposited osteoclasts remove necrotic bone, while the stem cells continue to differentiate into osteogenic repair cells. Hypoxia also attracts endothelial cells of adjacent viable vascular beds to infiltrate the band of sclerotic necrotic cancellous bone and fatty marrow, both of which have undergone dystrophic calcification. These new vessels supply osteoclasts to remove and remodel necrotic bone matrix and supply additional mesenchymal stem cells via delamination of pericytes from the outer walls of the neovascularization. These primitive pericytes differentiate into osteogenic repair cells that merge with the stem cells to heal the lesion. These reparative cell units are also reported to undergo neoplastic transformation. Neoplastic transformation of arteriopathy-derived bone infarcts via stem cell dysregulation have been reported in dogs, with osteosarcoma being the most common result. In another report of canine bone infarcts, 52% show evidence of repair, 48% had tumors. Tumor types include osteosarcoma, chondrosarcoma, fibrosarcoma, and pleomorphic sarcoma. Treatment and prognosis depends on the location, tumor type, and grade. Okay, materials and methods. A separated right capital physis with a displaced capital epiphysis was radiographically evident on the ventral dorsal and lateral projections of the pelvis. A diagnosis of slipped capital physis was made. A right cementless total hip replacement using a BFX collared stem and acetabular cup system was performed. A cementless implant was chosen based on the dog's young age and the absence of any other patient parameters that would favor a cemented implant. So we're going to go over the findings here, but these are the radiographs there showing the disease pre-op and then the post-operative repair. So in the radiographs, they show femoral medullary changes in the canal proximal to the entrance of the diaphyseal nutrient artery, which is the open black arrow, loss of medullary canal density proximal to the nutrient foramen and distal to the hyperdense sclerotic metaphyseal bone, extending proximally, which is a solid black arrow. The scalloped appearance of the femoral neck merged with a large lateral zone of radiolucent bone, which is the white star, showing bone loss medial to the greater trochanter in the trochanteric fossa. These secondary changes are from remodeling of infarcted bone. The medial and lateral radiograph of the right coxofemoral joint, so that's picture B, so those medullary changes and the displaced capital epiphysis are present. And then for picture D, osseointegration did not occur along the proximal lateral aspect of the femoral stem adjacent to the greater trochanter 6 weeks after surgery. This is the open black arrow showing a thin radiolucent zone. A narrow zone of bone resorption was present at the base of the femoral neck distal to the femoral stem collar and at the lesser trochanter. However, the implant fixation was stable and there was no pain on physical examination. So again, going to give you another picture as to what we're talking about here. Radiographs taken at the time revealed incomplete but satisfactory integration of the femoral stem and a thin zone of bone resorption at the base of femoral neck and lesser trochanter. 52 months post-op, radiographs showed a radiolucency lateral to the femoral stem at the greater trochanter. Periostitis was present at the base of the femoral neck with partial calcar resorption. There was also a small osteolytic lesion present adjacent to the cranial pole, the acetabular implant that was not appreciated at the time the radiographs were taken, but the implants were stable. The dog showed up 6 months later and found now progression of osteolysis at the greater trochanter apparent. Now these are the images that you're seeing here, so we'll go through those. For picture A, Periostitis was present over the greater trochanter, and there was osteolysis involving the medial aspect of the greater trochanter at the shoulder of the femoral stem. That's the black solid arrow that you see in that picture. Extensive osteolysis was present, new bone formation, and then in picture C, this is after the amputation, you can see 9 months post-op. There's a near complete osteolysis of the entire right hemipelvis, with only a portion of the ilium wing and ischium and a fragment of the ilium body remaining. The space is occupied by a soft tissue mass, and there's a metallic hemoclip that you can see from the previous surgery. So that's this mass here and loss of the pelvis. No bacterial growth. Biopsy was nonspecific, showing fibroplasia and lymphoplasmacytic and histiocytic inflammation. Tiny microparticles, maybe processing artifact or pigment, or less likely polyethylene particulate. In addition to the slipped capital physis, femoral medullary canal and neck changes were present proximal to the entrance of the diaphyseal nutrient artery, consistent with the arteriopathy-derived bone infarction. So the coxofemoral disarticulation, amputation was performed, and the results found, this is the pink picture now that we're looking at. In picture A, mats of poorly vascularized pleomorphic stromal cell tumors of stem cell origin, that's the solid black star, from fatty marrow mediated osteoclasts located in Howe-Ship's lacuna, which is the solid black arrows. And then picture B, pleomorphic stromal cells, and had large nuclei with prominent nucleoli, rare mitotic figures, fibrous stroma, but no amorphous matrix. Some of those features are consistent with neoplasm. So the biopsy showed pleomorphic sarcoma. Neither vascular nor lymphatic invasion was present. No metallic debris or polyethylene particulate was noted. Thoracic radiographs, 9 months after the amputation, found soft tissue nodules throughout the lungs and enlarged right medial iliac lymph node during ultrasound. Discussion: idiopathic arteriopathy-derived bone infarction caused by slipped physis, which necessitated treatment of total hip replacement, compromised the arterial supply to the proximal branch of the diaphyseal nutrient artery of the femur, would impact the blood supply of the proximal femur and explain the remodeling of infarcted spongiosa of the greater trochanter by stem cells. During the repair and remodeling of the infarcted bone, neoplastic transformation of stem cells occurred, resulting in cancer. The initial presenting radiographic abnormalities include a radiodense sclerotic epiphysis on the femoral neck, modeled loss of bone density, and features of remodeling bone infarct, a transverse band of sclerotic metaphyseal spongiosis compatible with infarction caused by a compromise of the proximal branch of the diaphyseal nutrient artery, a compromise of multiple epiphyseal arterial vessels had apparently caused the sclerotic bone of the infarcted epiphyseal spongiosa. This loss of bone support resulted in the capital physeal fracture. Transformation of a canine arteriopathy-derived bone infarction into a pleomorphic sarcoma is very rare. Pleomorphic sarcomas, formerly known as malignant fibrous histiocytomas, are a group of soft tissue sarcomas reported in species that include horse, pig, cattle, dogs, and cats. Organs reportedly affected have included spleen, digits, skin, subq, ilium. Low-grade pleomorphic sarcomas associated with back injury lack the anaplastic cellular features and high mitotic index of a high-grade malignant sarcoma, and they are recognized as nascent sarcomas that are thought to arise early in the spectrum of cancer transformation. Histologically, they can be confused with reactive fibrosis, especially with osteonecrosis present. However, they do exhibit cellular atypia and nuclear pleomorphism, which is consistent with cancer. In humans, pleomorphic sarcoma classified into 5 subtypes: undifferentiated high-grade pleomorphic sarcoma, myxofibrosarcoma, undifferentiated pleomorphic sarcoma with giant cells, undifferentiated pleomorphic sarcoma with prominent inflammation, and angiomatoid fibrous histiocytoma. Most are high-grade, aggressive, metastasized regionally and distantly. Histologic subtype: large size, high tumor grade, vascular invasion, location other than limbs, all influence the prognosis in humans, representing less than 2% of bone tumors. There is no evidence of granular metallic debris from the implants Evaluation for polyethylene wear particulate is best performed by using polarized light or electronic microscopy. There's also a histologic particulate algorithm to differentiate, to identify wear products using routine light microscopy. Given the absence of metallosis or polyethylene wear product, it's improbable the implants contributed to cancer formation. In this case, femoral head neck excision during the total hip replacement was not submitted for a histopathologic examination, which you should have. I mean, this is the big problem with this paper, is that if you're removing any part of the body that's abnormal, especially, then you submit it for histopathology. I mean, it's just insane not to do that. And it's not like cancer in really young animals is not reported. It's rare, but it has been reported. Anyway, that's what they should have done. If a capital physeal fracture due to a proximal femoral infarct has been suspected originally, the treatment plan would not have changed. However, the excised femoral head would have been submitted for biopsy. Then, with confirmation of the infarct, serial monitoring would have been discussed with the owners, given the potential for cancer transformation. That's my only problem with this paper, is that you should have biopsied it. I mean, it is not a hip replacement being performed for a dysplastic or arthritic hip. This is you're performing this because of a slipped physis, which maybe wasn't traumatic, possible bone infarction. So you biopsy the bone. All right, thanks everybody for watching the video. We'll see you in the next one. Take care.